AI agents are everywhere, automating tasks and making decisions at machine speed. But agents make mistakes. Just one rogue agent can do big damage before you even notice. Rubrik Agent Cloud is the only platform that helps you monitor agents, set guardrails, and rewind mistakes, so you can unleash agents, not risk. Accelerate your AI transformation at Rubrik.com. That's RUBRIK.com.
Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual. And today I have a guest that we, as pediatric emergency providers, rely upon very much. Today I'm going to talk to Jared, who is a respiratory therapist in our hospital here in Las Vegas. And if you are a PEM provider, you know very well how much we rely on those respiratory therapists, especially in the winter months when it seems that everybody has bronchiolitis, have difficulty breathing, needs to be put on high flow or even intubated. And we're all very good in choosing the medications, deciding what size tube we need. But let's be honest, from that point on, we really rely on the respiratory therapist to help us with the vent, with the settings, etc. That's why I brought Jared on the show to give us a little crash course on how do we mechanically ventilate our patients. So, welcome, Jared. Thank you very, very much for coming on the show. I guess I did not realize you post-call, so I'm super grateful that you're here. This is something that I wanted to do for a long time. You're busy, I'm busy. It took a while to get this scheduled, so I super appreciate your time. Let me just introduce you to the PEM Rules listeners. Jared is one of the only people who is actually originally from Las Vegas, right?
That's correct.
And you have been working at our hospital at Sunrise in Vegas as a respiratory therapist since 2013. You're also part of the flight team, which we really appreciate because you guys bring a lot of sick kids to the hospital and from the hospital. So Jared works in the transport team as a respiratory therapist. Jared, you studied respiratory therapy at the Pima Medical Institute for respiratory therapy and then got an undergraduate degree in addition to that in Tucson, Arizona. Is that right, Jared? Did I miss anything?
No, that was great. I'm happy to be here. It's a pleasure.
Wonderful.
Thanks for having me.
Oh, you're very welcome. So Jared, you kind of know the podcast a little bit. First question to you, the question I ask all my guests. I'm curious to know your intake on it. What is your definition of a good PEM provider? One who does what?
I think PEM providers have one of the hardest jobs as medical providers. You have to deal with a wide range of patients, all varying degrees of illness, and you see very sick patients. You have to deal with their parents, which I think is harder sometimes. You have to deal with a lot of things. So I've being able to work closely at our hospital, I've definitely appreciated seeing your leadership and your bedside manner and how you approach the care that you give. So I appreciate you, I've appreciated seeing you work. But ultimately, to go back to your point, I think a good PEM provider is someone who is, able to be assertive. They can manage a room under stressful or sometimes very tense situations. In the pediatric emergency, these are not easy situations to navigate, and I think a PEM provider that is able to take command of the room and is able to, take charge and is able to be a good leader in those really tough situations while also making difficult calls sometimes, when in care. I think it takes a lot to be a good PEM provider, and all those things. They can handle stress in chaotic situations. They can control all aspects of the emergency. And, they can control staff by, communicating clearly and kindly. They can help parents, I think, by being compassionate and honest. And then lastly, and probably more importantly, they can also, help the patient and put the patient at ease by, providing safe and competent care. So, and I've seen you do all those things. So kudos to you, Doc.
Thank you. Thank you. I appreciate it. Let the record say that I did not ask Jared to say any of those things, but I
That's
really,
true.
I agree with all those comments. I try to teach my residents and my fellows being calm, cool, and collected is a big part of being an emergency provider, because if you as the leader don't keep calm, it's all going to be downhill from there. And Jared, this is exactly why I wanted to have you on the show, because the most common reason I bill for critical care, or the most common reason for chaos in the resuscitation room, is a child with a respiratory illness. We know, for the most part, kids don't get into serious troubles from heart problems, from kidney problems. Sometimes it's from infection, but by all means, the most common the most common cause of a pediatric emergency is a child with a respiratory problem, bad bronchiolitis, bad asthma, etc. And this is why I'm so grateful you came on the show. And let me tell you, just Jared, briefly, one of my biggest challenges as a PEM doc is the fact that, in my training, and I think that's common for most people, I'm pretty good about intubating the patients. I know what size tube I need. I have my technique that I've been using for a while. And intubating the patient, not very hard most of the time, choosing the right tube, preparing, etc., and then manually ventilating the patient, also pretty easy for us. But when it comes to putting the child on the ventilator, I gotta be honest, I don't really have a good background education in that, what mode, how much, etc., and that's something that I always very, very much rely on you guys. So my goal for this talk is really, if you can just give us a crash course and educate the PEM Rules listeners on how do we ventilate a patient beyond, putting the tube and manually ventilating. What mode, how much, etc. Maybe we can go through some cases and you tell us how and what we do. What do you think about that?
Yeah, absolutely. I'm happy to help. Now, I think it's important to mention that being able to intubate, especially a small child from a neonate up to pediatric teenagers, that's a very important skill set to have, because
Sure.
if you have to get an airway, you have to usually get it pretty quick. We don't have a lot of time, especially if the patient is going to acutely decompensate. Timing is very important, and being able to successfully pass that tube. So if that is a skill that I obviously it's one you have, and I've seen you do it, and you're awesome at it. So good job.
Thanks.
It's it is difficult though. Intubating a baby is hard, and it's not always easy to do. But some of your listeners may work in rural facilities. They may work in small ERs where they're not used to seeing a pediatric patient. So on a day they have to intubate one of these children, it's going to be pretty stressful for them. And especially you get the tube in, and now what? You still
Exactly.
you might have to manage this patient for an hour up to several hours, while maybe a team like from a children's hospital like ours is able to get there. So you got the tube in, but what next? We've been to bedsides where because they're not quite sure how to manage the ventilator for a small patient, they've just been bagging for, they've been manually, bagging the child through the ET tube for hours, just because they're too scared to put the child on the ventilator. They don't know what mode, they don't know what rate, they don't know what pressures. So hopefully we can alleviate a little bit of that today. My goal would be to give you maybe just some basic, like you said, a crash course of general settings, where, if you put a patient on, you'll never be wrong.
Great.
You might need to fine tune it here and there, but you could at least get the patient comfortable. You can get them, adequately ventilating, and you can care for them during that time while you're maybe freaking out a little bit. So we've something I'd touch on is mentioning rural hospitals. We have the opportunity to go to some of these small little hospitals in Nevada, Arizona, Utah, California, kind of the surrounding states. And we often find that if they do put a patient on a ventilator, they're either being underventilated because they're scared to, maybe give the kid too much pressure or volume. They're scared about their little lungs overinflating, which I can appreciate that. But, sometimes you're not breathing enough for the kid, and the kid's really working, they still have increased work of breathing, even though they're on the ventilator. Alternatively, we've arrived at the bedside and they're given way too much support, where, the volume is way inappropriate for the patient size. And, now we're concerned about, we might have a pneumothorax. We might need to needle decompress the lungs now because we're filling the lungs up way too big. So, these are kind of, and then sometimes they get it just right. So we see the whole spectrum, too little support, too much support. So, hopefully we can give, some good easy guidelines that you could put a patient on for your listeners that could make them feel comfortable and a little more, safe.
Perfect.
Doing that.
Perfect. That's exactly why I wanted to have you on the show, and hopefully we can have a lot of people listening. So let's start with some general cases that I see quite often. And again, I have the pleasure of having you guys 24/7. Some docs do not. So the classic, let's say, 8 months old, with wheezing, congestion in the winter, pretty classic for bronchiolitis. And whoever invented the high flow nasal cannula, I am super grateful for those people. But unfortunately, sometimes suction, high flow, try albuterol, sure, but the kid is just not having it. So in healthy 8 months old with bronchiolitis, who's not significantly better on the high flow nasal cannula, working hard to breathe, what do we do?
Great question. I think these high flows nowadays are pretty amazing. I know at our hospital we use the Airvos, which is, I think, a fantastic machine. However, if I always, when we, sometimes these hospitals will call our team and ask for advice, like, hey, in the meantime, what can I put the patient on that can hold them over until you get here? So the first thing I say is, maybe let's not grab the tube just yet. Let's make sure we're given adequate high flow nasal cannula support. On some of these newer high flow machines that they're coming out with. And of course, I would, as a disclaimer, say, make sure you familiarize yourself with the equipment your hospital has. Sure. And, get a little more comfortable with it. But, a lot of these smarter, more intuitive high flow cannula machines that we have now, they recommend giving a patient about 2 liters per minute per kilogram. So just to keep the math easy, if you have a 5-kilo baby, put the kid on 10 liters. Let's start there and see where we're at. I don't want to walk in and find a patient on a 5-kilo baby on 2 liters and you're getting ready to intubate. Why don't we give a chance? Why don't we give adequate support with the high flow nasal cannula first? And let's see how the kid does. So I would say, one on our, 8-month-old bronchiolitis kid that's, probably could be 5 kilos, give or take. Let's make sure we're giving adequate high flow support first. Then, yeah, of course, if we're not, sometimes, unfortunately, suction, you throw the book at it, still not working. We're still tachypnic, still retracting, our blood gases are going the wrong direction. We need a little more support.
Yep.
Ventilators, over the years, they've come out with really good non-invasive modes. Kind of a more general one is non-invasive INV. We call it NIMV for short. And that is when you are using the ventilator to provide support, but non-invasively. So the kid is usually attached to some sort of like nasal apparatus that is providing a respiratory rate, a peak inspiratory pressure, a PEEP, and then usually a little bit of supplemental oxygen, a little FiO2. So very similar to invasive ventilation if you had an ET tube. It's just we're doing it, via nasal cannula. So I would say typically on our routine on our team is if high flow cannula is not working, kind of the next step is attempting to do one of these non-invasive type modes, and traditionally on a baby and you can use these on even young pediatric kids, we throw them on, they make these cannulas for, even, your bigger, pediatric kids, 5, 6, 7-year-olds. You can put the child on a rate, you're going to kind of want to use your rate as a guide, like take your patient, estimate what a normal respiratory rate is for the patient. You can go a little bit above, but, the difference with these non-invasive cannula modes is the patient's not triggering the ventilator. You're setting a rate, and all that's doing is, let's say you put the rate at 20 times per minute. What's happening is 20 times per minute, the ventilator is cycling between a peak inspiratory pressure and a PEEP. And the patient can breathe anywhere they want in that cycle. But what that's doing is that's just giving them a little more support. It's giving them a little more pressure in their lungs, and it's allowing those tidal volumes. It's basically allowing the child to take a deeper breath. But we're doing it non-invasively, and we've seen tremendous success with that. In fact, when I first started, we used to intubate babies all the time. Yeah. And since they've come out with that, we treat a lot of patients with these non-invasive, ventilator modes now. But I know we're here more to talk about the patient that's beyond that.
Well, let's say again, the reason of you coming on the show, we have done this. Now we have to actually intubate the patient, which doesn't happen very often, I got to say, thanks to everything you just mentioned. Right. But let's say we're there. What's next?
Yeah, I would say, so if I can give your listeners, let's say you want to try the non-invasive mode first.
Yeah.
We've moved on from a 10-liter high flow. We've given adequate high flow support. What's our next step? Okay, next step, why don't we try one of these non-invasive ventilatory modes, which, depending on the ventilator, they have all these trademark names, but it's all the same thing. It's a non-invasive, intermittent, mandatory ventilation that's delivering. So what is a good starting point? Well, I would say for our patient that's 8 months old, I would probably put that patient on a respiratory rate on that mode of about, anywhere from 20 to 30 breaths per minute.
Mm-hmm.
I would set our peak inspiratory pressure somewhere between 18 to 22 as a peak inspiratory pressure. Now that includes your PEEP, your positive end expiratory pressure. And then I'd set our PEEP somewhere, between 5 and 6. So, a rate 20 to 30, peak inspiratory pressure somewhere between 18 and 22. The most ventilators will have you set an I time, and kind of a standard I time we set is, about like half a second, so 0.5. And then titrate your FiO2 based on need. So, sometimes you can put a kid on that on, 21%. They just need the flow. They don't necessarily need the oxygen. But, give them the kid a little FiO2 with it as well. I'd start the kid at 30%. And if you need to give them a little more, go for it. Now, again, progressing, we need an ET tube.
Yep.
We've now intubated the patient. We're not going to be too far off that. I think, when you're invasively ventilating a child, I think it's important to remember that there's not one mode for everybody.
Sure.
Ventilators have various modes, but at their most basic level, you can ventilate a patient with by either delivering a set volume or a set pressure. Traditionally, in children and in babies specifically, we for safety, we typically ventilate them with pressure ventilation. In the adult critical care world, we tend to set a tidal volume and say, ventilator, give this much volume in the lungs, and this many times a minute, and that's fine for adult lungs because we have big lungs and they can take a lot of volume and it's not a pressure. But when we're dealing with children, we have to be very concerned about giving too much volume. So I would say our go-to mode in the pediatric and neonatal world is what we call pressure SIMV. Pretty much any ventilator you have will have it. Now, they might call it something a little different, depending on the brand. All these ventilator companies, unfortunately, none of them seem to get along very well. So they all have to call the same mode something different.
Okay.
But at its core, you're looking for a ventilator mode where you are providing a respiratory rate, a set pressure, and that's pretty much it. Yeah, so we're providing a rate, and so this many times a minute, we're delivering this much pressure into the patient's lungs. That's it. Every ventilator you have will have that.
Okay.
Like I said, they might call it the more popular is pressure SIMV, which the acronym is pressure spontaneous intermittent mandatory ventilation. I know it's a mouthful, but again, in its simplest terms, we're delivering a set pressure to the lungs, X many times per minute. And going back to our 8-month-old with bronchiolitis, I would say, again, our non-invasive settings and our invasive settings are not going to be too far off.
Okay.
Traditionally, with our younger patients, the goal for volumes in the lungs is we're looking for anywhere for about 4 to 6 mLs per kilogram. One of the beautiful things about these ventilators nowadays is they do all the math for us. Before you set that ventilator up, you can dial in the patient's weight. So if our patient's 5 kilos, you tell the ventilator, hey, the patient that I'm about to connect you to is 5 kilos. Think and dial it in. And then when we put our settings, the ventilator will tell us, okay, based on this amount of pressure, you are giving, 5, 6 mLs of volume per kilogram. And again, that's right on the money. That's what we're looking for. I would say on older kids, your target's, it's recommended a little more 6 to 8 mLs per kilo. And you kind of can make a judgment call if you're dealing with like a bigger pediatric patient or like a smaller baby or younger one. But I would say, if you're dealing with the younger patients, 4 to 6 mLs per kilogram of volume is what our target is. And, when you kind of cross that threshold into our older kids, you're aiming for a little more 6 to 8 mLs per kilogram on the ventilator. So how do we accomplish that? Well, set your rate. We're going to pick our mode, which again is going to be usually some form of pressure ventilation. Okay. Mm-hmm. So you're going to set your respiratory rate. I would say on our 8-month-old, I would probably set it, somewhere between high 20, low 30 breaths per minute. Okay. I'm going to set our pressure, probably peak inspiratory pressure. I'm going to set that about 20 to 22. And then I'm going to set my PEEP 5 or 6. And then because it's an IMV mode, we will set a pressure support. Now, what's pressure support? Well, pressure support on these particular modes of ventilation, the ventilator is only giving a full support breath based on your set respiratory rate. So if our set respiratory rate is 30 breaths per minute, but the patient is breathing 50 times per minute.
Yeah.
The ventilator is not going to deliver 50 breaths just because the patient wants it. We're still only going to deliver the set amount of breaths. The patient can still take 50 breaths per minute if they want. It's just on those extra breaths, they're going to kind of be on their own. And that's what pressure support is. Pressure support is only on those spontaneous breaths. The ventilator is helping the patient compensate and breathe through all that extra tubing, that long straw they're breathing through. So you can typically set your pressure support somewhere between 8 to 10. And you're going to want to set an eye time on that, where your ventilator will tell you, will calculate your IE ratio for you a lot of times. So I try to find somewhere between just a normal IE ratio of 1 to 2. And then your FiO2, which, a good starting point. If you've just coded a kid, then you usually want to keep that at 100%. If you're just intubating a bronchiolitis kid that's like slowly decompensating, you can titrate your FiO2 based on their SAT and based on need and, titrate it accordingly. But just to summarize, a good starting point when it comes to, a bronchiolitis kid, let's try to get our pressures where we are getting 4 to 6 mLs per kilogram of volume. So I would put that kid on a respiratory rate, just to keep it simple, of about 30 breaths per minute.
Mm-hmm.
I would set our peak inspiratory pressure somewhere between 20 to 22. I would set our pressure support 8 to 10. And then FiO2 based on, what our SAT is, to keep our target SATs if we want to maintain SATs above 95 or whatever. And if you set a patient on that, whether it's an 8-month-old bronchiolitis patient or even a 2-year-old, if you put a patient on that, I can tell you, you're probably never going to be wrong.
Okay.
You're going to be ventilating the lungs. Just watch your numbers. Again, the ventilator will do the math for you. It'll say, as long as you have that patient weight dialed in, it'll tell you, hey, you're giving this patient, based on these pressures, you're giving the patient an average of, 5 to 6 mLs per kilo.
Which is what we want. Correct.
That's perfect. That's right where you want to be. Okay. So
perfect. So that's a very good kind of simplistic way to say that. Still not very, very simple, but certainly make things a little clearer. I'm guessing that's one of the most common reasons I intubate a patient from a respiratory standpoint. Again, bad bronchiolitis, etc. What about, Jared, another scenario that happens, and I'm guessing, and you tell me if I'm wrong, is quite different. So every once in a while, I see a patient in status epilepticus. We have a lot of patients suffering from seizures, and that population is growing. A patient that I made him or her stop breathing because I had to provide a lot of anti-epileptic medications. So status epilepticus, usually you give Keppra and then phosphene, some other drugs. But at some point, if the patient doesn't stop seizing, we give phenobarbital or some other medications that really take away the respiratory drive. In other words, I'm intubating a patient that has normal lungs. He or she have no problem in the lungs. They just stop breathing because of the medications I gave them. What do we do then?
When we're dealing with a patient like that who, we might just be paralyzing for other reasons, but their lungs are healthy, then, that actually makes our job a little bit easier.
Sure.
Because with the bronchiolitis patient, we might be fighting with secretions. We might be fighting with, sometimes these are ex-NICU babies, and we're fighting with lungs that might, have all the trauma of being on a ventilator for a big part of their life. And we have to kind of overcome those obstacles. And, you may need to give a little higher level of support to fight against all those other factors. I would say with a child that we're intubating for another reason, in other words, not a lung problem, not a problem with the lung or airway in any, then you pretty much follow those same rules. We want to, based on the patient age, we kind of want to target, those tidal volumes somewhere between, again, on the younger patients, 4 to 6 mLs per kilo. On if it's like a 7-year-old patient, I would probably try to hit closer to like 6 to 8 mLs per kilogram. I would set an appropriate respiratory rate, maybe, high teens, low 20s for our respiratory rate. I'd probably maintain our pressures kind of in that same window, somewhere between 18 to 22. We might need to fluctuate, depending on, because you're going to set a pressure on a ventilator somewhere in that range. And then you're going to have to look at the measurements the vent's giving you. Like I said, there's not one setting for everybody, unfortunately. You can get pretty close. You can hold them over, but if you just in an emergency, you're dialing in these settings. Again, this patient isn't too far removed from our bronchiolitis one, and that our settings are going to look pretty similar. Our respiratory rate might be a little lower because it's an older patient,
Sure.
but I would set a pressure somewhere in the low 20s, and then I'm going to look at that ventilator feedback, and I'm going to trend what our volumes we're getting. I'm going to say, okay, on this breath, we just got 6 mLs per kilo. On this one, we got 7. On this one, we got 8. Now we're back to 6. So we're in a good range. We're ventilating this patient adequately. Now, if I put them on a patient on that patient on a set peak inspiratory pressure of 20, and the ventilator feedback is giving me that we're only getting like 3 mLs per kilo, then I know we're probably underventilating this patient. What do I need to do with our pressure? I need to go up. I need to increase our minute ventilation. So I can do that by either increasing my respiratory rate or increasing the amount of volume in the lungs. And with our pressure modes, we do that by increasing our pressure. So, if I put that patient on a pressure of, like I said, 20, our volumes are still low. I'm just going to go up on the pressure until I hit that window of now I'm delivering 6 to 8 mLs of volume per kilogram. Okay, now I can leave it alone. We're ventilating the patient. You can use your end tidal CO2 monitors. That's a good guide. It's not always perfect,
Sure.
End tidal's not really good if there's leaks or, if there's certain things, but it's a good window. It's a good guide. And then, ultimately let the patient chill out for a little while, get a blood gas, and then you can make vent settings based on that. But I would say on a patient like that, it kind of makes our job a little easier because all we're doing is we're not trying to overcome and compensate for a lung issue too. We're just trying to adequately ventilate them. That's it. So
Sure.
let's set our pressures make sure we're getting, for that older patient, 6 to 8 mLs per kilo. And if we're doing that, you're probably never going to be wrong.
Excellent. So again, that's a very good guide and kind of put it simply, because again, that's probably another fairly common reason I intubate a patient, because I gave them a lot of medication to stop seizing, and at some point the patient he or she do not breathe on their own. Jared, so we only have like 5 more minutes. I understand you wanted to give a shout out to a program that you found extremely helpful in managing the patient. Tell us briefly about that.
Yeah, so I'm actually I've been an instructor for a program called STABLE, which is an acronym for sugar, temperature, airway, blood work, labs, and then emotional support. That's kind of the acronym. But that it's geared more towards, kind of the newborn baby population. However, if any of the listeners were looking, because, I find, PEM providers tend to do, they do a really good job with the pediatric patient. I find sometimes where, they might be a little more, where they could familiarize themselves is more with the younger baby or neonatal type population, maybe that patient that's only 2 days old. And then especially, and then PEM providers are even a lot more comfortable with those than our, let's say adult emergency medicine providers that we work with that, see a baby once or twice a year.
Right.
So,
Absolutely.
I'm a real big advocate of this program. And just they're not paying me or anything, but I shout it out because I've seen massive changes when providers have taken this course. And all it is, it's like, okay, we've successfully resuscitated, this baby.
Yeah.
But now what? Like, just because we've resuscitated, all right, we have a heart rate, like we have the airway hopefully under control now. Now, what are we going to do? And it just goes into, things we can do for thermoregulation. We got to keep the child warm. We have to, maybe let's start thinking about, we resuscitated, but what's our sugar? All these things that we probably need to manage that, to prevent us from going backwards again. So we don't have to resuscitate a second time. What can we do to keep propelling the patient forward? So I just as a helpful tool that I've found very helpful that, when I first started, I discovered it and it was extremely helpful to me. And so I try to pass it along if I find helpful things. I would say, it's called the Stable program. It's excellent. Everyone I've ever had that's taken it has felt much more comfortable taking care of those little ones,
Excellent.
So shout out to that.
Well, thank you, Jared, very, very much for all this wonderful information. One quick thing before we part, the show, you get to choose the outro, and I guess you like Alice in Chains. You chose a great song. Was it Men in the Box?
Yes, Lane Staley, Alice in Chains. I think he's one of the best vocalists of our time.
I agree with you. This is Men in the Box, especially for you. Thanks again for coming on the show. Really, really appreciate it.
Thanks, Doc. It's been great. I appreciate you.
And that is it for today, guys. Thank you very much for listening to PEM Rules. I hope you learned from Jared and his extensive experience in what seems like a pretty complicated thing to do, ventilating patients, children on the ventilator. Thanks again for listening to PEM Rules. Thank you for the support. Please check out the Facebook page, check out the website, the store, and everything else in between. If you have questions or any other interests you want to discuss on the show, please let me know. I am always happy to hear from you guys. This is my attempt to do Men in the Box, especially for you, Jared. Thank you very much.
AI agents are everywhere, automating tasks and making decisions at machine speed. But agents make mistakes. Just one rogue agent can do big damage before you even notice. Rubrik Agent Cloud is the only platform that helps you monitor agents, set guardrails, and rewind mistakes, so you can unleash agents, not risk. Accelerate your AI transformation at Rubrik.com. That's RUBRIK.com.